Um, so good afternoon. I'm introducing the next session and we're going to get our skates on. It's the future of treatment and prevention. I'm chairing this with Bouke, and the first presenter is Richard Phillips, and he's going to talk about the trained immunity and the prospects of the Buruli vaccine. And I'll just introduce Richard, who needs no introduction, and he's a very familiar face at every meeting that I've ever been to on Buruli. Richard's always there. So he's a professor of medicine at the School of Medicine and Dentistry and scientific director of the Doherty Centre for Collaborating Research at the Kwame Nkrumah. I tried that a few times, got it right, now I've got it wrong. University of Science and Technology. He has 25 years of experience in the practice of medicine at the Komfu and Al-Qaeda Teaching Hospital in Kumasi, where he was an infectious diseases physician. He's been working on Buruli ulcer, neglected skin diseases, emerging infections, etc., for 25 years. Welcome. Thank you.
All right. Thank you very much, Paul, for that kind introduction. And thank you, Tim, and all the organizers for asking me to do this talk. So now we are moving into another area. We know that in the control of infectious diseases, there are three main areas you need to concentrate on. In the drug treatment, you need to concentrate on surveillance, and then you need to think about prevention. And they are all solidly sitting on lab diagnostics to support it. But today I'm supposed to speak on this trained immunity and the prospects of a Buruli vaccine. So in my outline, what I intend to do is first to cover the concept of trained immunity and what does immune protection in Buruli entail, and does early clearance occur? Where are we with Buruli vaccine research, and where are we going with future vaccine work? These are all really thought-provoking and difficult topics. We'll see what we conclude in the end. So the concept of trained immunity is a recent topic. When we're in medical school, when we're in the university, they taught us that memory had to do with the adaptive immune system. But recently, it's known that the innate immune system does remember. It does remember, and there have been a lot of publications to that effect, that the monocytes, the macrophages, the NK cells, they can be induced by previous vaccinations or colonizations or previous encounters with infections. And they do remember because changes do happen in these cells. There's this epigenetic reprogramming that happens, and physiological changes happen in the histones that allows them to remember these infections. And that is what the theory behind the trained immunity. And there's been a number of publications on this. We know in TB that about 5 to 10% do develop the disease. By the same principle that many are called but few are chosen, you have a sizable number of people who develop latent disease, and there are about 20 to 25% who probably clear the infection somehow. And it is thought that by the checkpoint model, those that the adaptive immune system serves as the second checkpoint, and the innate immune system serves as the first checkpoint. And so it is thought that people who live under constant exposure can't clear infection without the involvement of the adaptive immune system due to early clearance or highly effective innate immunity. This we underestimated, most of us did underestimate, because little work has been done in this area. And there's a lot of evidence that has come up in recent times about 13 people who were exposed, the US naval ship outbreak, that had no TST reaction after exposure. And it's also known that if you take adults and perinatal monocytes, there's increasing monocyte responsiveness during your lifetime. And it's also known that if you take twins, as they grow, there's immunological divergence that comes with time. It's also known that there's enhanced function of monocytes and NK cells after BCG vaccination. It's also written and known that BCG vaccination reduces child mortality irrespective, non-related to TB infection itself. So the question is, I'll try to walk through some of the work we've done to see what happens, what does immune protection in Buruli entail, and does early clearance occur at all? Because we've heard in some of the talks, snippets of this from some of the talks. We know already in some of the published data that with Buruli ulcer, early lesions do have clumps of extracellular mycobacteria and subcutaneous fat necrosis and sparse inflammatory infiltrate. But we also know that in healing lesions, you do find granulomas, and that finding granulomas themselves gives you the idea that the cell-mediated immunity is involved, and this is what we've always thought. And studies on the delayed hypersensitivity response study done by Stanford in 1975. In that study, he gave intradermal injection of Buruli in 45 patients. Early M. ulcerans disease had no reaction, and 76% of 45 M. ulcerans disease patients with healing lesions had a positive reaction, suggesting that there's a degree of T cell sensitization. So this we've always known, and we've been chasing this, thinking that patients that are recovering from BU should have engagement of the T cell sensitization. And there's been work published by Gooding in 2003, where he looked at the interferon gamma responses in BU patients and unaffected controls. And in that publication, there was acquired T cell anergy following infection, and this was published in 2003. What I don't know is whether these patients were BCG vaccinated. Then Prevot in 2004 also published this data on interferon gamma responses and IL-10 responses in patients with nodules and ulcers, Buruli patients. And he showed that the patients that had Buruli ulcer, the nodular forms had profound interferon gamma responses, whereas those that had ulcers had profound IL-10 responses, showing a bit of dichotomy. I mean, the sample size was small, but more evidence came up later. We also carried out some studies looking at patients with M. ulcerans disease. We've used an M. ulcerans sonicate, and then by Timothy Stinear also gave us plasmid proteins, specific M. ulcerans plasmid proteins. We've used these as well. So I'll show you some of that data. We've used flow cytometry, and we've also used other methods to find cytokines. So in this work, which was part of my PhD at the time, we looked at patients with BU, active disease, contacts, and non-endemic controls. And these were the interferon gamma responses that they produced. I was a bit surprised because some had made plenty of interferon gamma. We said, okay, that's maybe it's BCG cross-reactivity. And they also did strong IL-10 responses. And some contacts also did respond and had responses sitting there. We noted that as well. But then 3 years after, we also looked at when antibiotic treatment came in 2006, we started looking at the interferon gamma responses on such patients. And we described that the response to interferon gamma, was quite slowly developing in these patients, and that was the trend that we saw. They made it to this M. ulcerans sonicate, and that was the observation at the time. 10 years on, and Tim gladly gave us these specific M. ulcerans antigens to test, and we did it on patients and then contacts and then non-endemic controls. And interestingly, we had most of the contacts making and the patients showing that they had seen it before. They recognized these and did quite nice interferon gamma. They responded to it. And if you look at this next slide, the interesting thing was that to all the plasmid antigens that were proteins that were given to us, you could see the contacts doing very strong responses. The contacts all showed, and it set us really thinking why these contacts are doing such profound responses. And also, if you look at the Buruli patient, you can see that some of them do quite profound responses still of interferon gamma responses. And at that point, my mentor, Dr. Mark Jones, we started discussing, Richard, is it nice to do a study where those with the very profound interferon gamma responses will be left without treatment because maybe they are healing already? And I said, Mark, this is not ethical. The ethics committee is not going to allow us to do this study. So we looked at this study. I think this is one study that looks a little bit at the natural history of the disease. And it was this control trial that used clovarsamine several years ago, the Uganda group. And in that study, they showed that about 30% of the lesions went on to self-heal. And this is recorded. And also recently, there's been some data from Australia where 5 Australian patients achieved self-healing, and the median age was 47 patients with no recurrences, and healing without specific treatment, they concluded, can occur in small ulcerated lesions. So what were our conclusions? Maybe self-healing can occur when people mount a favorable immune response, or that maybe the M. ulcerans fail to secrete enough mycolactin or establish persistent infection in some patients. But it is interesting to speculate that maybe these high interferon gamma responders to M. ulcerans sonicate in the whole blood assays at baseline were patients who probably could heal spontaneously. And in contrast, these could have developed maybe latent disease or subclinical infections. I mean, these are all things that we've been thinking about. And Professor Gerd Plushka did this publication that I read, and on Buruli ulcer, the efficacy of the innate immune defense may be a key determinant for the outcome of infection with Mycobacterium ulcerans disease. I do believe in this, and that there is probably enhanced responsiveness of the innate immune system to secondary stimulation due to trained immunity. And this could have implications on vaccine development. We've also done some work using flow cytometry, and this is published, that confirms that there are multiple T helper 1 cytokine producing CD4 positive T cells that are induced in Buruli ulcer patients by flow cytometry, because the other assays we did had to do with cytokine assays, and different cells can secrete interferon gamma. So this flow cytometry confirmed that really these multiple T helper cells, cytokine producing cells, are present in Buruli ulcer patient. We've also shown that there are also antigen-specific B-cell responses in Buruli patients. And yesterday, Jonathan presented as part of his PhD, he saw a lot of memory B-cells that are enriched in Buruli ulcer patients. And there are actually changes in B-cell populations that happen with treatment. So something goes on also with B-cells. And we've also noted that even in patients that we've managed, in the fast healing ones, those that heal below 8 weeks of treatment, if you compare those with those that are slow healing, this is irrespective of some lesion size. You have some changes in the innate cells. So the invariant natural killer T cells are elevated in fast healers. We've been interested in understanding why some patients heal fast in even similar size lesions compared to those that do not heal quickly. So generally, my thinking and conclusion is that the innate and adaptive immune system may contribute to protection in Buruli ulcer, but a better understanding of the contribution of the innate immune system is highly needed, and the innate immune system's contribution to the host defense against infection and vaccine-induced immunity should not be underestimated, because probably it does. And there's been work that has been done on Buruli vaccine research, and I'll quickly show you what's out there. We all remember the study on the BCG efficacy, and there are two clinical trials on humans. The first one on TST negative patients, and the second one on a broad range of TST responses. And in those two studies, it was shown that there was 47% protection. And this protection didn't last too long. It didn't go beyond 1 year in that case. My studies also have been done, and we know the studies done by Professor Frank John Stinear, who was also Australian, who did work with BC vaccine in mice and showed that BCG was highly protective in mice, and especially with the small dose than the high dose. Recently, Steve has published some work on vaccine work in Buruli, and I reviewed all this, and most of the work that has been done has been to try to improve on the BCG work that was done in the past. And single dose has been tried, again booster, and it didn't show that the booster helped. And also Converse and others worked with different types of mice and showed that biopsy mice were better protecting than the C57BL6 mice, and there were strong cytokine responses and IL-17 responses. And also, Fraga in 2012 showed that it used BCG versus mycolactone negative ulcerans. And there he showed that, well, there was delayed swelling in all vaccinated, and there was high interferon gamma and early granuloma formation, but there wasn't complete protection, actually. And also Hart and others. Hart has done a lot of work. I reviewed those in 2015 and 2016, and using BCG versus BCG that is expressing M. ulcerans antigen 85A. And there it showed that there was delayed time to peak swelling, and there was high CD4 positive memory cells and high interferon gamma responses, but protection wasn't complete. And then there was this work also done by Watanabe in 2015 with dewaxed M. ulcerans that reduced swelling at 14 days and halted swelling. And in that study, it also showed high in immunoglobulin G or T helper 2 responses in that study. There were other studies that, because of time, I will not put up here, but there's been work also done with immunodominant proteins, and they displayed poor efficacy in mice despite potent antibody responses. So that conclusion is there. And there's a large study that also has been done by one of our PhD students with a composite subunit vaccine using combining mycolactone as a modulator, antigen 85, and polyketide synthase enzyme KRA. Formulated with KIL-A as adjuvant. And to go to the results, you see that this vaccine was superior to BCG and the avirulent M. ulcerans strain. There was no swelling of the foot mice foot pad of mice in combinations that utilize the triple composite vaccine 14 weeks after observation. And there was a combination of a mixed pro and anti-inflammatory cytokine responses that conferred absolute protection against ulcerans disease in the mouse foot pad. And they concluded that you actually need this mix of pro and anti-inflammatory because in the other studies, you saw that there were profound TLP1 responses that were not completely protected. And some lessons have been learned in this. So I'm concluding. The lessons learned that few studies exceeded the protection offered by BCG in mice, and even mycolactone deficient ulceran provides minimal immunological protection from subsequent challenge compared with BCG. And recombinant live whole vaccines that generate immunogenic antigens in either M. marinum and BCG appear to provide protection, although complete sterilizing immunity was not demonstrated. And the dewaxed whole cell ulcerans, although it was not compared to BCG, seems promising, as well as the composite vaccine that I just mentioned. But we should not forget that BCG work has been done. A lot of BCG work is coming out to show that it does increase responsiveness of human monocytes and natural killer cells to secondary stimulation. So what should our future look like? We need to understand the precise innate and adaptive immune effector mechanisms leading to protective immunity. And also future studies should explore novel and improved vaccination strategies that more effectively induce classical, adaptive, and also trained immunity against ulcerans. And vaccine research will be limited by availability of funds anyway. So if you go into the literature, you see that this is the case. Thank you very much.
Thanks, Richard. That was a very good, broad overview with lots of things to think about for the future. If there's one question, I'm happy to take it. It's at the back.
Thank you. Hi, Richard, for the nice overview. I'm going to ask you a kind of provocative question. Can you hear me well? Okay. I'm going to ask you a kind of a provocative question. Given the low incidence of the disease and the limited number of patients that we are having in the different scenarios in which we have the disease, how realistic is to develop a vaccine for Buruli ulcer? Because, I mean, for TB, you need a super large cohorts of patients to catch a small incidence and a small difference. I don't know if this would be achievable for Buruli ulcer.
I mean, I agree with you. I mean, that will be a challenge. I mean, if you need to recruit large numbers. But yesterday, we also heard of the controlled human infection model because of that very reason, to use approaches that can help us achieve the same results. But I agree that you need numbers. Apart from the funding, you need numbers in carrying out studies to be able to develop a proper vaccine.
And it's my pleasure to introduce someone else who needs no introduction. Dr. Paul Converse has been working on immunology, pathogenesis, tuberculosis, leprosy, and last but not least, Buruli ulcer since the 1980s. And for the last 20 years, Johns Hopkins and his team have studied different combination therapies against M. ulcerans in preclinical models. So it's a pleasure to hear you talk about the future of therapeutics.
See if we get it to work. So, yeah, I want to first of all thank very much the organizers for providing the scientific and social environment and chances to interact, and also to see this beautiful part of the world, as hard as it might have been to get here. So, in addition to the future, I think we need to look a little bit at the past and the present to see where we are. And so these first few slides I've adapted from a set that was provided by Richard Phillips. And so as we know, until the early 2000s, surgery and skin grafting were the only real modalities we had. And then some mouse data generated by Jacques Rosset and colleagues in Paris showed the efficacy of rifampin and streptomycin. And what's important here, and I think we have some transformative changes in treatment and others that were very important, yet relatively incremental changes. But what was important here was the combination therapy. Somehow in Buruli ulcer, the concept of multi-drug therapy, which we knew to be very important in TB and leprosy, was overlooked. Streptomycin was shown by here in, well, actually in the States by Australian Frank Fenner to be basically prophylactic. It was not he did not show cure with streptomycin. Rifampicin was also used as monotherapy, and it too was not curative. It would halt the growth. But putting them together looked very promising. There were some human studies that showed that efficacy was very good, and so the WHO went on to recommend 8 weeks, which was a conservative decision to go for the full 8 weeks. And then, of course, one of the challenges was giving streptomycin for 8 weeks. As Chip points out, that means 56 shots, which is not so pleasant for the patients, and it also means Richard has to work on Saturdays and Sundays to administer it. So it's a 7-day-a-week commitment from both patients and providers. So Chip, I believe that's Chip, but some of these were done by both Chip and Richard. So you could cut down the number of days of streptomycin to 4 weeks, 28 days, and then move to an oral antibiotic for the succeeding 4 weeks, and then take that down further, only 2 weeks of Rif-Strep, and then finally we have the regimen of today. The Rif-Clary was shown to be as good as 8 weeks of streptomycin. The other thing to notice here is the time. The first studies took a year or two, and then they were 3 or 4 years, and then 4 or 5 years. So the challenge of doing the studies was very challenging. We have some ongoing studies now. So we have Rif-Clary for 8 weeks together with nitric oxide infused dressings. We'll look at it a little bit, as well as Rif-Clary versus a higher dose of Rif and another sort of dressing intended to enhance healing. And then, as Santi just presented, we have the RCA 4-week versus Rif-Clary. And as Eugene told us, we have now the Telasobec going on for 4 weeks. So again, the ongoing trials, 3, 4, 5 years, but Telasobec put down to a few months. So it's a very encouraging development. So yeah, so as we know, Rif-Clary was shown to be as effective as Rif-Strep, and so this is the array of pills that now need to be taken for 8 weeks according to protocol. So let's take a look at some of the trials that are ongoing just now. So we have the Buruli trial in Ghana, where they are doing the standard of care in one arm and supplemented with the nitric oxide dressings. And the target recruitment was 142 patients. The primary outcome was healing at week 16, and then secondarily to look at enhanced immune profiles in these patients. And the timeline was nearly, well, I guess 3.5 years. However, and this is the dressing system we can look at. But the main issue has been, as we saw from the epidemiology, is how do we recruit the patients in Ghana and in other parts of West Africa. And so as of a month ago, only 30 participants, 15 per arm, had been recruited for the trial. And then for the next study, Richard took note of studies led by Till Owenson in our group, and here we saw that Rift strep, which tends to be at oh, sorry. Okay. Yeah. So yeah. Okay. Okay. How about this? Okay, so yeah, Rift strep often is at least as good or better than Rift flare. Is this? Yeah, and hold it to my mouth. Okay, I never was a pop star. Okay, so increasing the dose of Rift together with and keeping the dose of clary constant, we can see that there's a dose dependent killing of Mycobacterium ulcerans in the footpad. Best, of course, was at the highest dose of 40 milligrams per kilogram of rifapentine. We didn't see the dose effect, but it was clearly comparable to a higher dose of Rif. I should point out that at week 4, these last 4 groups were all culture negative. So there's definitely some encouraging signs to be found with using a higher dose of rifampicin, which has also, of course, been shown to be helpful in TB. And then the other trial that Richard has been leading is therefore to look at the higher dose of Rif together with clary and these dialkyl carbamoyl plus chloride dressings to see if that could enhance healing. And recruitment was, target was 122 patients, and wanted to see time to clearing of viable ulcerans and the proportion of patients healed at 20 weeks. Timeline, roughly 3 or 4 years. But again, how do you recruit the patients? It's been a real challenge here. So 42 participants were recruited as of last month. And I think both of these, the nitric oxide and the dialkyl carbamoyl trials are going to be evaluated. I think it's next month in Ghana. So, and then as Santi presented earlier, so I don't think we need to spend a lot of time on this, but what is the benefit of adding IMUC-III? And in contrast to what was seen in Ghana, apparently they were able to recruit a large number of patients, partly by using a clinical screen with subsequent PCR confirmation. The benefit, of course, is of having the IMUC-III is that the patient has been treated and has taken it. Of course, there is the disadvantage that again we're up to 56 shots for those patients. So that work is also being evaluated now. And so let's go on to the current star of Buruli ulcer treatment. So it was Talosabec was originally designated Q203, and it was found to be bacteriostatic against TB. And so we'll sort of review some of the slides that were shown earlier. But so the electron transport chain can be blocked at the level of the BC oxidase, targeting the QCRB here. But TB, and especially 837RV, just shrugs that off and uses the BD oxidase, which is less efficient than the BC oxidase, but permits the survival of the TB organism. And then studies were done in TB where they used a knockout of the BD oxidase, the CYDA gene, and suddenly it is very susceptible. So if we had a BD oxidase inhibitor for TB, we'd be in pretty good shape potentially. So that, and I always wonder if the TB Alliance doesn't have a BD oxidase inhibitor somewhere in its back pocket, but Eugene isn't revealing that at the moment. So So these studies were done by Lamprecht et al., I believe, in Durban, and also by Kalia et al. So M. ulcerans, however, has a mutation in CYDA, and this was shown in work by Nicole Scher and a large team in Gerd's lab, and they found that instead of encoding a tryptophan, here we have a stop codon, and so effectively there's no BD oxidase in the so-called classical M. ulcerans strains. However, I should point out that in the ancestral strains, there is still that. And the ancestral strains, where are they? Those are in Japan, where there's not as many cases, fortunately, but that will be a challenge for Talosabec treatment in Japan, potentially. Also in Mexico, we found, but I think there have only been 5 reported cases in the last 50 years in Mexico, so it's not a major focus of disease. So then a number of studies have shown that mice infected with M. ulcerans are rapidly cured by Talosabec, bacteriologically and clinically, so to speak, in a week or less, and possibly even with a single dose. So let's look at some of those studies. So by infecting mice in the foot pads, and so and grading the swelling on a scale of 0 to 4, so rather advanced swelling in this experiment before the start of treatment. And so we had the untreated mice, so of course those go on to a level where they have to be sacrificed for humane endpoints. Rif strep is quite active together. Also, rifapentine and clofazimine in this study was very effective. And then we had at least 4 multi-drug Q203 containing regimens, assuming that we needed combination therapy even with Q203. And they all gave essentially the same result. It didn't matter what we put together with Q203. They were all very active, and so the mice achieved a swelling grade reduction down to 1 or less, and essentially looked normal by the end of 6 weeks. So, and then the bacteriological index. So again, they started bacterial burden rather, they started very high, took a longer time with Rif strep or rifapentine and clofazimine, but any of the Q203 regimens, basically they were at or near culture negativity after 2 weeks of treatment. So where are we? Okay, so compared to the standard of care, or a former standard of care, the adding Talosabec to PC or other combinations, we got a very rapid response. So then we said, well, maybe we don't need those other drugs. Let's try monotherapy, Talosabec. And so in this study, and this is the number of parameters were tested, just showing one here. So this swelling was a little bit less than in the previous experiment, but treatment was for only 1 week. And so we could see that by the end of that week, the foot pads were essentially looking normal and continued to look normal. So we had a good clinical response very rapidly, and so on. And so this is done at 3 different doses of Talosabec, 0.5, 2, and 10 milligrams per kilogram. Likewise, the bacterial response was also very, very effective, and so the mice were in the Q2 regimen were culture negative by 3 weeks, and the highest dose at 5 weeks in this particular experiment. So again, compared to the standard of care and compared to Rif monotherapy, Talosabec treatment provided a very rapid and enduring treatment response. And then is this slide that Eugene showed earlier. So here we have treatment essentially for 1 week, except that the doses are divided differently. So one group, they had just a single day of treatment at 10 milligrams. These mice also got 10 milligrams over a week, but spread out over 3 days. And these had 2 milligrams per kilogram daily for 5 days. And so here we see that that the foot pad, the burden of bacilli, and this is at a very high level in this particular experiment, but essentially they're almost culture negative at 5 weeks after starting treatment. So 1 week of treatment, 4 weeks rest, and then and then testing again at like 13 or 14 weeks after 13 weeks after the completion of treatment. All the mice in these two groups were culture negative, and in this group, 6 of 8 of the mice. So the once daily treatment was marginally less effective than dividing the dose over the week. And so again, even as single dose monotherapy, the result is a more rapid and enduring bacterial clearance. And then we did some PK as well. And so this is after a single dose of Talosabec, 2 minutes. Oh, okay. So we'll try to wrap things up. But what's important here is that even at the lowest dose, we're many-fold a higher concentration of Talosabec than the MIC. The MIC is 0.00075 micrograms per mil. So it's very active. And we were able to compare this with a published single dose study in humans, and essentially the 2 mg per kilogram dose or the 10 milligram per kilogram dose was comparable to the 100 or the 320 milligram dose in patients. And also it had a very good safety profile. Other PK studies that were also done at the same time showed that if you treated for 1 week and then waited 4 weeks, the Talosabec concentration was also still well above the MIC. So finally, I think you're going to be inundated, but this is the wonderful message, is that the Talosabec is being translated into a human trial, and it's being done here in Australia, and the target was for 40 patients. When I wrote to Eugene in late September, he says, well, we have 8 recruited, or actually Maria responded, you were on vacation. But as of the end of last month, up to 25, and as we know now, Steve and Dan have 37, 38, 39 patients. So essentially the recruitment has been completed, and the availability of patients is very much reflected by the epidemiology presented in day 1 of this conference. So in conclusion, Talosabec has remarkable potency against M. ulcerans. It results in a rapid reduction of foot pad swelling, has very good clinical response, also very huge effect on the bacterial burden. And so, as mentioned, the infections with the so-called ancestral strain in Japan, where the MIC is about 4 dilutions greater than against the classical strains. And in the Mexican is only maybe 2 dilutions difference, but there is a difference in the MIC. So in 20 years, treatment of Buruli ulcer has gone from surgery and skin grafting with frequent relapse to 56 daily shots and pills to 112 pills, and now perhaps we can reduce it to 1 to 5 pills. So thank you very much. And just want to acknowledge my collaborators in the lab, and to Jacques Rosset, who got us all started on this journey many years ago.
Thank you very much. Time for one question. Sandeep.
Thank you for the nice presentation. Paul, considering the costs associated with these type of trials, do you suggest something like adaptive sampling or response adaptive randomization, things like that? Because as
Sorry, could you speak up just a little
yeah,
bit?
I was considering the costs associated with the sample numbers to achieve some of these trials with the adequate power. Do you suggest something like adaptive sampling and things like that? Because there's quite a lot of cost associated with studies like these, isn't it? And for a disease with declining burden, do you think that the resources are available, or maybe newer sampling strategies should be adopted to reduce the numbers and still attain the power, isn't it?
Well, yeah, I certainly haven't been involved in the design of the trial. And maybe Dan or Steve could address, or even Eugene could, or Richard. Okay. Yeah. Oh, yeah.
Yeah, I think he's asking about adaptive trials, and I think that's the new way forward, looking at innovative ways of recruiting patients into trials, and the MRC clinical trials unit uses that approach very well, and it's something we have to look into because of the reducing.
So this would be like the simplicity TB trials and so on. Okay, yeah, okay.
Okay, for the next speaker, it's my pleasure to introduce my colleague, Associate Professor Dan O'Brien. Well known to us already, he's an absolute powerhouse of passion and experience in Buruli ulcer treatment in Victoria. He's made a really big difference by carefully recording what he does and publishing it so all the rest of us can learn. He's the Director of Infectious Diseases at Barwon Health. He's the Deputy Director of the Barwon Southwest Public Health Unit, and he also works at the Victorian Infectious Diseases Service across the road. And he's working with Stephen Mui on this fantastic study that we're also fascinated with. So Dan, could you please talk to us about the new Australian guidelines, which will have to be updated next week, I suspect. Thank you.
Thanks, Paul. I was thinking the same thing myself. We're about to present 2024, which will be obsolete in about 6 months. No, but you're also sharing an introduction to your own work as well. So the idea today was, and it's hard to get it all out in 15 minutes, is to just, we've had an update in the expert consensus statement guidelines for the management of Mycobacterium ulcerans in Australia. It's due out hopefully in the MJA in the next 1 to 2 months. It's almost been accepted. And so I just wanted to run over some of the principles without being able to go through the whole detail today. Paul originally started these in 2007, was the first iteration with the panel. I helped him update that with some other members in the audience in 2014, but it's 10 years since they've been updated. Quite a lot has changed, so it was time to update. The process has been led by a core group, Steve Mui, Paul himself, Victoria Cox and myself, but a larger group as well that involves not only infectious disease and public health physicians, but primary healthcare providers and most importantly, wound care experts with experience in managing Buruli ulcer. There was an initial draft document developed that was based on evidence from current research and recent clinical experience. And then we met in July of this year for a consensus meeting via hybrid teleconference where scientific evidence was discussed and the absence of evidence, clinical experience was also discussed. The consensus statement was then refined, peer-reviewed, and it's been endorsed by the Australasian Society for Infectious Diseases, and I said hopefully soon to come out. Diagnosis, basically, once again reiterated that the diagnostic gold standard test is, of course, the PCR. That has a high sensitivity and specificity. Most commonly in Australia, it's used on a swab of the wound, but sometimes on a biopsy, not very often aspirate. And we do advise that it's performed on all lesions. Just a little bit of caution for those who are less experienced is that in our experience, about 1 in 20 initial PCRs are negative, thought probably because the swab technique's not correct or they've swabbed non-ulcerative lesions. But just wanted to remind everyone that if it is a clinically suspicious lesion, you have a negative PCR, that doesn't exclude the diagnosis to ideally repeat it, preferably with a biopsy, but at least a swab. The management principles, antibiotics remain the first-line treatment. We still recommend an 8-week combination for most people and a 2-drug combination that is rifampicin-based, but slightly different to WHO guidelines. We do include either a fluoroquinolone or a clarithromycin-based regimen. And as previously, we don't recommend injectable agents. Haven't really used them here now for 15 years. This is based, of course, on the randomised controlled trial of Philips and others in Africa, but noting that they're a very different population. They're children, they don't have comorbidities, they're not on other medication, that we did feel we also need to rely on the extensive clinical experience and published observational data around the use of fluoroquinolones in the Australian experience, and therefore we recommend them that they can equally be used depending on physician preference, patient preference, previous side effects, drug interactions, those sorts of things. We recommend, if you're unable to use rifampicin, that clarithromycin ciprofloxacin regimen is used, though you do need to monitor for QT prolongation with ECGs because they both prolong the QT interval. Not a lot of evidence on its effectiveness, but some clinical experience. And in pregnancy, we suggest rifampicin and clarithromycin. I just wanted to, I know for a lot of people in the audience this is well known, but I think part of the guidelines is to understand the natural history of a Buruli ulcer wound that's in Australian experience that's treated with antibiotics, because the classic thing is that it gets worse before it gets better, and it's important for clinicians to understand that, but also for them to pass that knowledge on to their patients so that people don't get unusually concerned when it happens. So the first thing that I was discussing yesterday with Carol and others is that what you do see in the lesion, sorry, this is a graph in the blue, just shows the amount of induration, which is, as you can see here in the, I've got a thing, is the swelling around the ulcer, which is measured just like you would a MAN2 test. And the purple is the actual size of the ulceration, that you'll get a reduction in the first 1 to 2 weeks of about a 40% reduction in the amount of swelling. So that's normal. And I don't really understand the mechanism, but at least it tells you the antibiotic seems to be working. But then over sort of 4 to 6 weeks, you start to get the increase in the swelling again, and of course, secondarily, the increase in the ulceration. Sorry, and with the size of the ulceration, that 70% will have an increase, and the median increase is about twice the size. And that by about 12 weeks, you're still quite an inflamed wound in general, but by about 14 weeks or so, in this case, the inflammation starts to settle. And once the inflammation starts to settle, then the wound starts to heal, and you heal a wound by about 3 to 4 months, or an average of 4 months in the Australian context. I think one of the really important things to understand as far as managing the wounds and observing the wounds is when we charted wound healing in the Australian context in the Bowen Health cohort, there was a linear relationship between inflammation around the wound and wound healing, so that the wound healing basically didn't begin until the inflammation resolved. So it's really important to get rid of the inflammation. And then, of course, the time to heal is dependent on the size of the initial lesion. So if it's less than 2 centimetres, it's 3 months, 2 to 4, it's 4 months, and if it's 4 centimetres or larger, that's a 6 months time period. So that's why it's also really important to see if we can get wounds, mechanisms to heal wounds quicker. Why is it different in Australia to the African context, for instance, is that we have real problems with our antibiotic tolerability. So this is data for, again, the Bowen Health cohort that shows that 1 in 5 patients will have to stop one of their antibiotics due to a severe reaction, and 15% of those people end up in hospital from that reaction. So, and if you're over 60, it's 2 in 5. So we really struggle with the tolerance of the antibiotics. The median time to antibiotic side effect is about 4 weeks. And again, it's basically the same between the rifampicin, clarithromycin, and the rifampicin fluoroquinolone regimens. But that's a real issue that and takes a lot of experience and knowledge to manage those reactions. The second thing is that The average age in Australia is about 60, so most people are already on other medications, have other comorbidities. We have a lot of trouble with drug interactions, and rifampicin, clarithromycin and fluoroquinolones all interact with a lot of drugs, so that needs to be taken into account. This is just an example of one patient who had 20 drug interactions to consider. We have for the first time this thing recognised that you can treat lesions, specific lesions for 6 weeks. This was based on, again, observational evidence from the Bowen Health Cohort published a few years ago. But importantly, that it is a selected population. So they were all adults, they all had ulcerated lesions, they were less than 3 centimetres in diameter, and there was no underlying immune suppression. And also recognise that although the antibiotic regimens are very effective in our context, there is a failure rate. And when we looked at the failure rate again in the Bowen Health Cohort, and it was perfectly illustrated today on our patient panel, the adults, male, more than 90 kilograms and taking a rifampicin clarithromycin regimen, and that was the experience today. And it's generally because the doses, the recommended doses in people who are heavier is smaller, but also through the drug interactions with rifampicin and clarithromycin. So that's led us to say that for patients with a combination of risk factors, and I won't in the interest of time list them all there, that a shortened course of antibiotics is probably best avoided. And you may also consider a fluoroquinolone in your regimen because that has less of a drug interaction with the rifampicin. But also, there's insufficient evidence at this time to basically recommend increasing dose of your milligram per kilogram for your antibiotics. Surgery is not required to heal wounds, we still say that, but there is a role for adjunctive surgery in a certain number of situations to either reduce healing times, avoid or reduce the duration of antibiotics, or to help manage paradoxical reactions. There's 4 basic surgical approaches that we describe. First is just debridement, which is removal of necrotic tissue or inflamed tissue. There's conservative excision, which is basically excising the lesion but not going through macroscopically normal tissue. There's a curette, which is just a way of debriding or excising, macroscopically excising just the lesion under a local anaesthetic. And there's wide excision, where you're actually going for cure, so you're getting wide margins through normal tissue. And just to walk you through a couple of those, debridement, for example, here's the graph once again. You can see at 10 weeks, you've still got a lot of inflammation, the wound's not healing, and the wound's still very sloughy. So as I said before, it's not going to heal while it's still inflamed. You can clean that up surgically. Here you can see 4 weeks post-debridement, a beautiful clean looking wound which heals 6 weeks post-debridement. So has a real role in helping to heal wounds quicker. Here's another wound that's just not healing. What is it there? 13 weeks into treatment. Instead of debriding it, in fact, this person just had a conservative excision and a direct closure, and the wound's healed within 3 weeks. But you can see the scar's quite significant, and of course you need a general anaesthetic for that, but that is sometimes used. This is a busy slide, but I just wanted to outline that this is experience again through the Bowen Health Cohort, where we had people who through drug interactions had to stop their treatment without getting a full 8 weeks, or they chose to stop early, but also had adjunctive surgery. And in the yellow box, anyone who received between 14 and 28 days of antibiotics, regardless of whether they had positive histological margins, all of them were cured. And so that's led us with time and experience to in certain situations where you want to reduce your antibiotic duration through antibiotic toxicity or through patient choice, that you can combine a shorter course of duration with a conservative surgical excision. Curative excision is still a possibility, and we talked again with one of the patients this morning, which was very interesting. So if you've got a lesion that's small, it's in an area you can cut out and directly close. I don't think, if you need a skin graft, for me, that's no longer appropriate. That you can, and you have negative histological margins, there'll be a 95% cure rate with that. The slight caveat on that is, here's a patient from late last year who had a small lesion on the calf on the left. He had terrible drug interactions and comorbidities that made antibiotics a nightmare. So he had a wide excision and actually required a skin graft. 6 months later, he had a recurrence at his knee. So 5% of people have a second lesion. Surgery alone, of course, without antibiotics doesn't deal with the second lesion. And so there is that risk of recurrence. Some of the things that will lead to recurrence at a high rate are positive histological margin, immune suppression, and older age. But what we're really keen is that we don't see this aggressive surgical treatment like we used to with vascularized flaps to heal lesions. That's no longer appropriate. Just made some comments to recognise again that the early identification and treatment of paradoxical eruptions is important because they're associated with increased tissue necrosis and delayed wound healing. Paradoxical reactions again occur, as most people would know, because it's basically a reversal of the mycolactone-induced immune paralysis in the lesion that leads to an enhanced immune response. In the interest of time, I don't want to go through too much, but just that you can diagnose it histologically. On the left, at the start, you see no inflammation in the first two slides, lots of acid fast bacilli. 6 weeks in, when you get the reaction, very inflamed. If you look at that thing here, as someone mentioned earlier this week, and no acid fast bacilli. So histology, you can see it. And clinically, this is what it looks like. Once again, get the normal response with the reduction in the swelling and slight ulceration, but then an intense swelling that leads to increased ulceration more than you would normally see. It's really important for clinicians to recognise that it occurs in about a third of people, but it's not always in the local wound. You can pop a ulcer either locally or in a completely distant body part, and it's not a recurrence, it's a paradoxical reaction. It's an unmasking of a previously unrecognised lesion. But also that 20% of them occur after antibiotics have ceased, because people always think when a lesion comes back after you stopped antibiotics, it's failure. It's most often, in the first year anyway, a paradoxical reaction. Microbiology doesn't really help because they're AFB positive and they're PCR positive, and the culture takes 12 weeks, so it's not very useful. So generally you do rely and fly by your seat of your pants, Bouke, as you discussed. But I think clinically they do look a little bit different. Necrotic lesions on the right are, much more undermined, yellow, whereas the paradoxical reactions often are a bit more granulomatous, not so undermined, look slightly different. If you're at risk of significant tissue loss, which you are with paradoxical reaction, this can be minimised with the use of steroids. We recommend 0.5 to 1 milligram per kilogram. Just an example here of significant swelling. Starting corticosteroids, the swelling can be controlled and the level of ulceration doesn't necessarily increase. Difficulty being actually getting them off the steroids. Or surgery can help to reduce the inflammation, increase wound healing, because of course it's removing the necrotic and inflamed tissues that's causing the paradoxical reaction. So very inflamed lesion, surgically debrided, and the paradoxical reaction heals and the wound heals within 6 weeks. I think this is probably the most important part of the talk for me, is that I think, as I said earlier, the longer I work with this, the more important I realise that good wound care is, not only in the African context, but ours as well. And that we've put a new section that wasn't in before, actually specifically on wound healing. Again, I haven't got time to go through it all. We've got a table in there that'll have the 9 important principles around wound healing, and Hubert today outlined those very well. But just to basically say, we view it as 3 stages. The cleaning stage, where you're just trying to remove the necrotic and inflamed tissue. The wound healing stage, once it's clean, to try and optimise and speed up the reepithelialisation. But then there's the wound protection phase after it's healed, because the wound takes quite a period of time to strengthen and it can be damaged, but also you need to work on the scar minimisation. There are a number of different agents that can be used. I won't go through them in detail today. But the other really important point for me is the value of an experienced clinician who manages wounds in cleaning them up and debriding them. There are specified GP clinics often with wound nurses, and Jodie was part of the panel in this thing. She does an amazing job at actually managing wounds in the clinic in Blairgowrie. But it might be through a wound clinic at a hospital, or it can be through patients or relatives who are trained and understand what to do. But you can probably save 1 to 2 months in wound healing by having good wound management. So I always try and encourage people to get good care for their wounds, because they'll save a lot of time. We have a section on children specifically this time. Again, I won't go into too much, except to just recognise that children get more severe lesions, and that they're often non-ulcerative, but they actually tolerate the antibiotics really well. So they're different to the adults. They have a higher rate of paradoxical reactions as well, but we still recommend specialist referral for children. And that's all I thought I would have time to say. Thank you.
Thanks, Dan. So I'm happy to take a couple of questions. We're going to leave out in the program, it says it's going to be a panel discussion. We'll get rid of that so that we can come back in by 3:30. Is that right? Or 3:40? Okay. So a couple of questions and then afternoon tea. Okay. Looks like, Chip, sorry. Chip. Yeah.
Thanks for the very nice overview. The combination of rifampin and you mentioned fluoroquinolones, but you didn't specify. I'm sure you would like to avoid drug-drug interactions with the chance of reduced drug exposure. Could you be explicit about the quinolone that you pick?
Yeah, sorry. We use ciprofloxacin here, basically. Where there is the option to use moxifloxacin, but to be honest, in the older population, it's well, it does have that drug interaction, as you say, with rifampicin, but it's just not very well tolerated at all, and it's also more expensive, so hospitals don't like to pay for it.
Thanks a lot for the presentation. I was wondering what is the incidence of paradoxical reaction and if they're correlated with the size of the lesions at the start or any other clinical parameter?
Yeah, thanks. That's a good question. It's about the different studies we've done in Australian populations, 20 to 30%. To be honest, everybody gets a little bit, you know, it's at what stage do you actually call it a paradoxical reaction? There are various definitions that have been used in the trials, but, you know, a significant clinically concerning paradoxical reaction would be about 20 to 30%. And yeah, the people are more at risk are those who have the edematous lesions. So those larger edematous lesions, you can often look at a lesion at baseline and say that's going to get a bad reaction, and it almost always will. And those who are immune suppressed also have a higher risk of developing. And we did find as well those who had been on amikacin way back at the start, which I felt was probably due to its bactericidal action, that you would get a paradox. And so I guess we were fearful that we might see that with Telasobec. We have to wait on the data for that, but that's also one of the slight we may see with Telasobec, yeah.
Thanks very much, Dan. So look, let's thank all the presenters for the session we've just been through.
Thanks to the organizers for giving me the opportunity to present our work. And I think it's maybe nice that I'm one of the last presenters because about half of my slides have already been presented. And the other half has already been undercut. So I could just stop here. But I spent 2 days coming to Australia, so let's just go on with it. So I'm going to talk about structural activity relationship studies that we have done at the Swiss TPH. And like we all already know, BU treatment is quite lengthy. So we still do drug development to, at least for one thing, try to shorten treatment or get maybe easier to administer treatments. And we know that the mycobacterial energy generation pathway, as was already mentioned earlier, is a good target for drug development. We know this because it's a validated target. So several drugs act on these targets. And one of the stars of the show now is Q203, which acts on the major cytochrome of Mycobacteria. In any case, given that this pathway is very promising for drug development, so what we have done is some more early drug development processes. So basically, we focus more on the cytochrome, the main cytochrome, to find other compounds that react similarly to Q203, so they affect the same cytochrome, but they do not bind in the same way that Q203 does. And the first, oh God, this is horrible. And the first of them is the aryl vinyl piperazine amides, APA compounds for short. So one reason why we focus on these two scaffolds is because, according to our chemists, they are very simple to synthesize. And we heard this morning that Q203 can be quite difficult to synthesize. So for these APA compounds, they were first identified in 2013 in a high throughput screening activity done on some GSK compounds. And they were found to subsequently to be active against M. ulcerans as well. So we did this work in collaboration with Karl-Heinz Altmann's team at the ETH in Zurich. And basically, they synthesized a whole panel of APA compounds for us, and then we tested the activity against the classical and ancestral lineage M. ulcerans strains. And essentially, since it's an SAR study, we check for what changes in different parts of the molecule can do for the thiophene parts, the benzodiazole, and the central piperazine. And very briefly, if you change anything in the thiophene part of the molecule, you pretty much lose activity. So there are very few changes that still had some activity, but most changes in the thiophene completely killed all activity against M. ulcerans. On the other hand, if you changed the benzodiazole, then we found that we could do a bit more modification and they still had some activity against M. ulcerans. But some of them still caused loss of activity, but a lot of them still had activity against M. ulcerans. And again, if you changed anything in the central piperazine, also was detrimental to the activity against M. ulcerans. So something as simple as just saturating this bond was enough to kill all the activity. So for the APA compound, you really shouldn't change anything other than the benzodiazole moiety. So one curious thing that we saw, oh God, okay, so my slide doesn't show here. There was a whole bunch of compounds here. In any case, one thing that we noticed was that when you changed the benzodiazole moiety by adding alkyl groups, we found that the longer the length of the alkyl chain, the more the activity. So this was 2C, 3C, 10C, like that. So it was a longer alkyl chain, but you can't see it here. I don't know why. But basically, as I said earlier, we check for the activity against the classical and ancestral lineage strains because the classical ones do not have this secondary oxidase. And what we saw was that they were only active against the classical ones. All the ancestral lineage strains were completely insensitive to this. But one other thing was for these APA compounds, they were quite toxic against cultured rat L6 cells. So for further development, you would need to find a way to balance toxicity and activity against M. ulcerans. So that's for this set of compounds. The next set of compounds are the aminoquinazolines, or AQ compounds in short. They were also first identified in the same high-throughput screening that found the APA compounds, but they've only, activity against MTB has only been shown, so nobody has yet checked for M. ulcerans activity. And one of the key findings of this SCR study that was done to check for activity against MTB was that when you fluorinated at this position, they were more metabolically stable in vitro. So what we did in collaboration with partners from the BASF was to screen a whole panel of AQ compounds, again, against classical and ancestral M. ulcerans strains. And we checked for changes for N modifications, S modifications, and for fluorination at this point. And what we found quite briefly was we could do a lot of N modifications. So this is just a small part, subset of the compounds. But changing things at the end group was very well tolerated. We could put very bulky subunits there and it was still active. What they did not like was when you had more charged groups at this point. But on the whole, N modifications were well tolerated. In contrary, we couldn't have a lot of S modifications because this completely killed activity. And this was in contrast to what was shown for M. tuberculosis, where the ethyl group at this point was more active than the methyl group. So we know now that you cannot do too many S modifications and still have activity. And then, like I said before, they found that the fluorinated groups were more metabolically stable. So we wanted to see what happened when you had fluorinated or non-fluorinated groups. And we didn't really see any trend to say. We couldn't say that having the fluorine was better or worse against ulcerans. But what we could say was if you want to develop them further, that you can stick with the fluorinated ones because they still had activity against ulcerans. Yeah. And again, like I said, we checked for activity against the classical and ancestral lineage strains, and they only had activity against the classical lineage strain. So this confirms the reported target being this main cytochrome. But compared to the APA compounds, these compounds were much less toxic against rat cells in vitro, and they had very low MYC values. So therefore, we could have quite good selectivity indices. And we think that for further development, we will really prioritize those ones that are fluorinated at this 8th position because they are quite active. So in summary, we screened the panel of APA and AQ compounds because they are simple to synthesize and they also act against the target of Q203. And consistent with this proposed activity, they are more active against the classical lineage strain than against the ancestral lineage strain. And the AQ compounds were much more active. And really, I don't know what happened with the formatting. It's completely changed what my slides look like. But with that, I'm already at the end of my talk. And like I said.
Thank you very much, Louisa. Are there any questions? Tim.
Thanks, Louisa. My question, how do you know, is there previous data to show that of what the molecular target is of these compounds?
So for the APA compounds, they actually did do modeling studies to show that it was binding to the QCRB, where Q203 binds, but not in the same position. So when they did functional studies, they could see that, for instance, if you had Q203 mutants that were resistant to Q203, they were still susceptible to the APA compounds. For the AQ compounds, they haven't yet tested this, but there is an analog that also binds to QCRB. So they are very similar in structure. So it's safe to assume that it also binds to Q203, to QCRB.
Thank you, Louisa. Santiago, welcome back. University of Zaragoza.
Thank you, it's me again. Let's see. Okay, this is my name, but actually it should be Peter Viletovic. This is a presentation on behalf of Peter from UCL, University College London. We are working with a group of Oscar de la Pascua in actually introducing modeling and simulation to Buruli ulcer to try to optimize regime and dosing in therapy development. So in here, and you see the difference. It was prepared with a PC, not with a Mac, so we don't have problems with the formatting. Okay, so as we were discussing in our previous clinical trial, the selection of the dose, rifampicin, clarithromycin, amoxicillin, clavulanate, the selection of the posology and the selection of the duration was actually empirical. We didn't have any real basis behind this, and I realized with Telasevec it's actually the same thing. So it's a pragmatical approach and an empirical approach to actually dosing selection. And one thing we were quite concerned, it was about, okay, amoxicillin clavulanate is typically dosed 3 times a day, but we are going to be doing this twice a day. So it's going to be working or not. So we started this modeling program to try to see if actually by modeling we could estimate if it was true or not that these 2 dosing a day would work. Just a background, when you do all this modeling, you take into account the dose of the drug you are giving, and this is influenced by if it is oral, intravenous, frequency, etc. Another important thing is the pathogen susceptibility. And with these two things, typically you can generate things like in the graph below that you have your PK profile and your MIC, and you calculate or the Cmax or the time over the MIC to actually infer activity. But with this, there is a limitation that we are not taking into account, which is the exposure and the variability in the persons, in the patient. And this is what we are integrating with this modeling approach. So what we are doing specifically for amoxicillin clavulanate, a beta-lactam, is a probability of target attainment. It is well described in the literature that beta-lactams are time over the MIC, is the PD driver of activity of beta-lactams, and that you need at least 40% of the dosing period has to be above the MIC value, right? So, and this is why you are giving 3 times a day, because the PK of the beta-lactams is very fast eliminating. Here, what we're trying to do is actually to integrate this with the in vitro data that we have in combination with rifampicin and clarithromycin, and see if we were able to actually maintain this exposure. So what we're doing is we generate data, in vitro data, and with this, they actually can simulate the profiles. They also simulate the profiles of the different drugs, so rifampicin, clarithromycin, and amoxicillin clavulanate. This is integrated in this probability of target attainment, and also we introduce this position on the skin, okay? And with this, we estimate or select what would be a dosing selection for this. So the objectives, as I mentioned, were to optimize the dose and to see actually if we can use all this to inform design of clinical trials. This is the general scheme of what we are doing. As you can see, there is a literature review. We get information from the literature. We have the PK models. We integrate the MIC values. This is a work done with MIC values. In the poster, we presented kind of an advanced modeling with in vitro time kill assays that we perform. But with in vitro time kill assays, what we try to infer is treatment shortening. Here we were looking at a probability of target attainment with amoxicillin clavulanate. And then we actually run the different aspect of the exercise. So here we get our virtual population, and we try different dosing schemes, okay? And then we have our MIC values that were generated, and we take into account the MIC values of the drugs alone, but also of the drugs when in combination as well. And then we perform all these clinical trial simulations in which we try to assess the time over the fraction of the time over the MIC. With this, we actually went to test different types of regimes, okay? So I'm trying to walk you through this. This is what we are doing in the clinical trial, rifampicin 10 milligrams per kilogram body weight, once a day, with clarithromycin twice a day, and amoxicillin clavulanate twice a day. Then we are doing the same thing, but only with amoxiclav once a day. That was our main question. Here, what we are doing is actually giving the same dose of rifampicin, but fractioning into a dosing administration. And here we are doubling the dose of rifampicin, but giving twice a day. And here is the same thing, but only once a day. And then we also test whether if we remove clarithromycin, if we further increase rifampicin, or if we remove rifampicin. So these are the different scenarios that we are actually testing in this exercise. This is an example of what we are getting. This is a scenario 4 that is actually the one giving the best PTA for amoxiclav, which is doubling the dose of rifampicin and twice a day, which makes sense because rifampicin and amoxicillin, they have a very strong synergistic interaction. So if you maximize the co-exposure of the two drugs, is where you are going to have better responses. And this is something that we are also taking into account, that in 24 hours, when you treat a patient, you are seeing different scenarios, right? So here is where we have rifampicin, clarithromycin, amoxicillin, but at some point, clarithromycin is washed away. So we are in only 2 drugs. This is again with the next dosing, but at some point we lose rifampicin, and at some point we lose both of them. So we have different scenarios of co-exposure of the different drugs. And these are more or less the results. So here, as I said, beta-lactams, the dogma is 40% of the dosing intervals. Here we take different targets, but we take as good something that is safe over 60%. And what we can see is that the best performance in which in all, even at 90% of the target, is the one that you are doubling the dose of rifampicin. But for this is the one that we are doing in the clinical trial that is actually working. And what we see is that we really need amoxicillin twice a day and rifampicin. We had done amoxicillin only once a day, according to the modeling, would have not worked, but twice a day, that was a pragmatical decision, is good enough to maintain the exposure of amoxicillin clavulanate. This is the same exercise, but this time taking into account the skin exposure. The numbers are a bit lower because the penetration on the skin gives you lower concentrations, but still is matching and working. And just to wrap up, the conclusions to summarize, although I've been talking about all this, is that with the group in UCL, we are really trying to get modeling and simulation and use in vitro data to actually get a better idea how to optimize the dosing. In our specific case for rifampicin, although this is modeling and needs to be experimentally validated, but the dosing could be, and the posology could be further optimized. Clarithromycin is probably not needed. As Richard Phillips is doing with his high rifampicin and has been demonstrated, increasing the dose of rifampicin is also beneficial, and probably splitting in combination with amoxicillin clavulanate would be the optimal one. And with this, it was quick to the end of the meeting. Thank you.
Thank you, Santiago. Questions? Okay, that was a bit of a tie between Chip and Dan. So Chip.
Thank you for rushing us through this modeling. What came up in my mind was we have autoinduction of rifampin so that drug exposure reduces over time, as maybe after 2 weeks of the same dosage, the actual exposure because of autoinduction is significantly reduced. Did you include this information in your modeling?
What we did include was the interaction with clarithromycin. In that one, you got me. I need to check with Oscar La Pascua. I'm not sure about that. But the interaction with clarithromycin was included.
Okay. But maybe autoinduction is even more pronounced than the drug-drug interaction.
Dan.
Thank you. Fascinating talks. So I'm just thinking about in our situation where we have drug toxicity and maybe you can't use rifampicin or you can't use clarithromycin. Do you think on your studies you could say substitute augmentin in for rifampicin and have augmentin clarithromycin, or vice versa, substitute augmentin for clarithromycin and run with rifampicin augmentin? Do you think those regimens?
So what we saw here is just focus on ensuring exposure of amoxicillin clavulanate.
Nothing on effectiveness.
On the effectiveness, this is something that we are doing. And I would say that removing rifampicin is not a good idea. You could go with removing clarithromycin and doing just rifamoxin.
Any further questions? Okay, thank you, Santiago. So I think I get to introduce Professor Tim Stinear. Is that right, Tim? Tim's a young PhD student who shows quite a lot of promise. Thank you, Tim.
That's right. And if Paul thinks I'm a young PhD student, then it tells you how old he is, I guess. So, anyway, it's been quite a ride. We've just got a few, look, at this stage of a Buruli ulcer conference, or indeed any conference, we're all ready to go home. So we will make this a concise but thoughtful wrap up of the last 3 days. I did have a few remarks. I wonder if I can, I think I'm just going to, yeah, that's quite a photo. If you look back through your memories, if you look back through the program, you'll see that we've covered what many conferences would try to run in multiple streams over multiple conferences. When you go to a Buruli ulcer conference, or I suspect any neglected tropical disease, you see a dedicated group of people that are trying to do everything. And in 1998, we had lots of challenges ahead of us. And since that time, we've met many of the challenges that were sort of laid down then to try and work out how it was being spread, at least here locally, to come up with better treatment regimens, to improve diagnostics. And we've been able to address many of those challenges. And of course, many remain. But it's groups of people like this that are willing to work together, that are willing to put aside their differences, at least eventually. We are only human, so let's give ourselves some leeway. But remarkable work has been done by a small group. Of course, there's more to be done, and I'll come back to that theme in a minute. We actually have some remarkable drone footage for those that made it down to the coast yesterday, but we'll post that down the track, along with all the photos that we've collected from the meeting, subject to making sure we're not violating anyone's disclosure, non-disclosure sort of policies. Another thing, yeah, let's perhaps a bit of housekeeping before we come to best poster. We will make the entire every session was recorded, I think, perhaps barring a few technical glitches. It is our intention to make those publicly available, as well as all of the presentations, the slides themselves. We will send an email to every presenter just to get your authority to do that. And perhaps if there's things you don't want made public, then we'll have to do some editing. Ideally, we would like to make everything we've got here available. I mean, it's a principle that Kingsley will often remind us that, you know, not everyone can get to this meeting. Not everyone's going to hear us today or the last 3 days. So let's try and get the messages and the things that we've discussed available to as many people as possible. Kingsley, I might just ask whether you wanted to address the remaining conference. Did you have any closing comments you'd like to make, or are you happy for me just to wind things up? Did you? Okay. I did want to raise that there is a WHO neglected tropical skin diseases meeting in end of March, March 26 and 27, perhaps, Kingsley, or 25, 26. So please think about attending that meeting. Heather Jordan has suggested that perhaps we could have a side Buruli ulcer meeting in association with the Skin NTD meeting. Rather than doing polling now, Heather, I would say anyone that thinks that they would like to support that initiative, could you perhaps chat with Heather at the conclusion of this session? Is that okay? Yeah. Very good. Now, we had 2 prizes at this conference for up-and-coming scientists that are at an early stage in their training. At least we hope that's who we're going to give this to. The first one is the poster prize, and I will declare no conflicts here. I didn't assess any of the poster prize assessment or the short talk, but we're going to announce our best poster prize. These were assessed by an expert panel of judges. And the winner, and if you could just come forward to receive your certificate and we'll take a photo, was Dr. Andrew Bulgens for his poster. Yeah, Andrew. Maybe we've got Christina then. Handshake. Right. All right. Now we have the best presentation. And this was assessed over the 2 days of the short talks from the eligible presenters. And the winner of this presentation is Mr. Kwabena Owasso Boateng. For his well, what do we say about prizes? They're good for those that win them, but it leaves those that didn't get a prize feeling a little left out. I would say, of course, the judges had a difficult time. And so please don't be discouraged if you did not get a prize. The scoring was very tight, so very difficult to choose. But anyway, congratulations to our winners. Congratulations to all of our early career presenters. I'm just going to finish with a couple more, 1 or 2 quick reflections. Actually, I shouldn't have done this because it's an emotional trigger for me. But anyway, we bookended the starting of the conference with these 2 doyens of Buruli ulcer. And I think just putting them up here was just to remind us that they had a couple of themes that are good for us to carry on with when we leave here. One of them is do high quality research, be prepared to publish quality over quantity. So that's a message for me and for all of us. Be prepared to admit when you're wrong was another theme that they put forward. And state a hypothesis that we can test and disprove. And that was John Heyman's one of his contributions to the presentation, to the conference here, is that he put forward ideas that subsequently didn't hold up, but they took us forward. And so all of us that are trying to address the really troublesome enigma of transmission in Africa of Buruli ulcer, we need good hypotheses that we can test and all the other things that are going to help us take transmission understanding forward. So also collaboration. These 2 have epitomized collaboration. They have networks that extend around the world over decades, have built incredible friendships with many of us, perhaps all of us here. So stronger together. And Kingsley, I think this is one of your enduring messages, stronger together. It's why that you've led a Skin NTD initiative to bring everyone together that has an interest in this space. So really good messages for us. And I have a personal challenge for myself, and it's not just for me, but can we eliminate Buruli ulcer, at least here in Victoria? At the minute, we're on the threshold of losing control of Buruli here, and that's not to overstate it. But there is, I think, with the knowledge we have, a chance for us to eliminate Buruli here, and then to take our learnings and share them as we go with anyone here or anyone around the world that's interested in trying to eliminate Buruli. Big challenges. I know that simplifies a lot of the complexities around working in this space. But that's, I think, the challenge that we can take now that we have generated so much understanding of this disease. Thank you to everyone that contributed to this meeting. You guys, the hardcore Buruliers that are left here at the end of day 3. But behind the scenes, there's been a team to make this happen. We thank our sponsors who have provided the financial support, including you that have paid your registrations to make this happen. But there's some personnel as well we'd really like to give a shout out to. The conference organising committee, and you can see their faces there. This was taken before they signed up to be conference organisers. So you can imagine, why they look so happy. We had 6 a.m. meetings here in Melbourne, which were 10 p.m. meetings in the UK. Only our US colleagues had the 2 p.m. meeting at that stage. So I hope they appreciate our sacrifice. So anyway, very good. A really good conference organising committee to work with. So thank you, guys. So perhaps a round of applause for that. And so, okay, the conference organising committee have the fun job, but there's actually the people that have to bring us all together and do all of the logistics. And Angela Donald, Christina Krashi, Hasina Walpola, Chloe Beckett, Chuet Huang, Che Gongzhou, who you met yesterday on the bus, he was the one cracking the whip, making us get on and off on time. But so thank you to all of you guys. But before we do any applause, I just want to give a very special shout out to Jess, sorry, really should not cry when you do these things, but Jess has been magnificent throughout this. So please, a round of applause for all of our behind the scenes people. And Jess, yeah, I should have warned you, there's a crying pathology in my family, and I have a very, I have a very highly expressed crying gene. Anyway, it's not a bad thing, but it is disabling. All right. Okay, so IMUC attendees, thank you. Go home safely. If there's nothing else to say, I just thank you all again for making this such a wonderful meeting. We've done some good. We've got, messages to spread, more work to do, of course, but safe home, and look forward to the opportunity to see you again somewhere at some time. So thank you.